Good afternoon, this is Dr. Faisal Khan. Welcome to Houston Medical Clerkship, Grand Rounds. Today we have a very interesting topic of autoimmune encephalitis presented by Dr. Aswathi. She's from SDM Medical College, Karnataka, India, aspiring to become a neurologist. She's already presented one previous presentation. This is her second presentation during her neurology rotation at Houston Medical Clerkship. And good luck, Dr. Aswathi.
Thank you, Dr. Khan. So, autoimmune encephalitis comprises of a group of non-infectious immune-mediated inflammatory disorders of the brain parenchyma. It has a prevalence of around 13.7 in every 100,000 people, and the incidence has increased between the years 1995 and 2005. In fact, then it was 0.4, and it has increased to 1.2 between 2005 and 2015 because of improved detection of the autoantibodies, and there is a slight male predominance of 2.7. The etiopathogenesis includes immune response against neuronal autoantigens with the production of antibodies. So these antibodies are classified into three categories. The first one is antibodies against the cell surface antigens like NMDA receptor, AMPA receptor, GABA receptor, glycine receptor, and D2 receptor. And antibodies against the synaptic antigens like SGI1 and Cas2. Antibodies against intraneural antigens, that is also previously called onconeural antigens. It can be ANA1. It can be associated with small cell lung cancer like ANA1. Can be associated with cancer of ovary and breast like PCA1. Can be associated with Hodgkin's lymphoma like PCA-TR, and can also be associated with cancers like breast and testicular cancer, which is anti-MA. And they can also occur without an association with autoantibodies, which are called seronegative autoimmune encephalitis. So this shows cell surface antigens like NMDA receptor, which is attacked by the autoantibody and absorbed into the into the neuron and becomes dysfunctional. And this shows the synaptic receptor autoantibodies, which are blocked by the autoantibody. Cell surface and synaptic antibodies have been shown to be likely pathogenic and are thought to be responsive to immunotherapy and have less association with tumors, while infections like HSV are known triggers of this. And examples, like we said, NMDA receptor, dopamine, D2 receptor, GABA receptor. Onconeural antibodies are non-pathogenic usually, but represent markers of T-cell-mediated immunity against the neoplasm with secondary response against the central nervous system. So here the antibodies are 70% sensitive and 80 to 90% specific. But these antibodies does not correlate with the disease progression. Seronegative autoimmune encephalitis represents a disease category with novel yet to be identified antibodies or T-cell mediated disease. So this shows the T-cell mediated immune response to the neurons and also B cells produce autoantibodies which attack the neurons. The clinical features are usually rapidly progressive dementia, psychiatric symptoms like hallucinations and psychosis, seizures, movement disorders like ataxia, dystonia, myoclonus, and orofacial dyskinesia, faciobrachial dystonic seizures with hyponatremia, which are specific to LGR1, sleep disorders like insomnia, sleep-wake cycle disturbance, peripheral nerve hyperexcitability, which are specific to Cas2, autonomic disturbances, and also GI manifestations like diarrhea, gastroparesis, and constipation, which are specific to DPPX. So this is a summary of the autoantibodies and their chemical features. Like anti-ANA1 causes encephalomyelitis, which can be cortical limbic encephalitis and brainstem encephalitis, cerebellar degeneration, sensory neuropathy, autonomic dysfunction, and likewise among the synaptic receptors, among the plasma membrane receptor, we have NMDA receptor, which causes psychosis, insomnia, seizures, behavior changes, memory impairment, autonomic dysfunction, catatonia, and coma. And also among the synaptic receptors we have SGI1 and Caspr2. So SGI1, like we said earlier, it causes limbic encephalitis, seizures, and rapidly progressive cognitive decline and hyponatremia. So I would like to explain a few of them. Anti-NMDA receptor encephalitis predominantly affects children and young adults, and the common age of presentation is 12 to 45. Commonly associated with ovarian teratoma, which is 94% association, followed by extra-ovarian teratoma, which is 2% association, and other tumors having 4% association. Herpes simplex non-encephalitis is no trigger for this, like I said earlier. Patients may progress from behavioral changes to catatonia or mutism. So an important differential here is neuromyelitis of, differential here is neuroleptic malignant syndrome, because many patients are initially treated with neuroleptics for the behavioral symptoms when they present early. Anti-SGI1 and anti-Caspr2 encephalitis, commonly known as VGKC-associated encephalitis. It can present with Morgan syndrome, which is characterized by neuromyotonia, pain, hyperhidrosis, weight loss, severe insomnia and hallucinations, and also limbic encephalitis. So among this, SGI1 is secreted a synaptic protein that interacts with transmembrane proteins called ADAM22 and ADAM23, and also to form a transsynaptic complex involving potassium channels and AMPA receptor. Clinical spectrum of anti-SGI1 encephalitis usually comprises limbic encephalitis, hyponatremia, and seizures. So, half patients who develop this can present with faciobrachial dystonic seizures, which are characterized by a brief unilateral contraction of the arm, often progressing to face and the leg, lasting 3 seconds and occurs several times a day. Most patients present with brain MRI hyperintensity intensity of medial to temporal lobe, which here you can see the complex that is formed by SGI1, ADAM22, ADAM23, and AMPR with the anti-SGI1 antibody here. And this MRI shows the hyperintensity intensities of the medial temporal lobe. Anti-GAD encephalitis. So glutamic acid decarboxylase catalyzes the conversion of glutamic acid to GABA. It can present with stiff person syndrome, cerebellar ataxia, epilepsy, and limbic encephalitis. So stiff person syndrome is characterized with muscle stiffness resulting from poor contractions of agonis and antagonis, painful spasms, and pronounced startle responses. Anti-DPPX encephalitis is DPPX is a subunit of potassium channel expressed in the hippocampus, cerebellum, striatum, and myenteric plexus of the gut. So it is present with neuropsychiatric symptoms like agitation, confusion, myoclonus, tremor, startle reflex, seizures, and stiff person syndrome. And the prominent GI symptoms like diarrhea, weight loss can precede the neurologic symptoms. And there is a good response to immunotherapy in this case. So the diagnostic criteria is diagnosis will be made only when all the 3 characters are present. That is, subacute onset should be there, that is progression within less than 3 months of working memory deficits like short-term memory loss, altered mental status, or psychiatric symptoms. And one of the following should be present, that is, new focal CNS findings, seizures not explained by a previously known seizure disorder, CSF pleocytosis, MRI feature suggestive of encephalitis. And also, there should be a reasonable exclusion of alternative causes like HSV encephalitis. Diagnosis is done by MRI of the brain, EEG, which can be non-specific. Blood tests can show the autoantibodies and can also rule out infection. Then CSF can show lymphocytic pleocytosis. We should also screen for tumors of disease onset if suspected to be paraneoplastic, like CT scan of the chest, PET scan, mammogram followed by MRI for breast cancer, and for pelvic tumors we should do ultrasound followed by CT of the pelvis. If initial tumor screening is negative but patient has antibodies that are typically paraneoplastic, the screening should be repeated every 3 to 6 months. followed by screening every 6 months to 4 years. So this is the MRI of the brain again, showing the anatomical differences. This is for limbic encephalitis, as we have seen earlier. This is cortical and subcortical encephalitis. Striatal encephalitis shows hyperintensity over here. Diencephalic encephalitis, brainstem encephalitis, and meningoencephalitis. Treatment differs. It depends on whether it's paraneoplastic or non-paraneoplastic. So in case it is paraneoplastic, the best way to treat is aggressive cancer treatment and immunosuppression, but it has a poor prognosis because it's usually irreversible neuronal damage by the T-cell mediated response that we saw earlier. If it's non-paraneoplastic, it can be treated with steroids and IVIG and also plasma exchange. This has a better prognosis. And immunomodulators can be used like mycophenolate, rituximab, alemtuzumab, natalizumab, tocilizumab, and eculizumab. The differential diagnosis can be frontotemporal dementia or Alzheimer's disease if the patient presents with rapid onset of dementia, or prion disease like CJD, psychiatric disorders like depression, pseudodementia, schizophrenia if the patient presents with hallucinations or behavioral changes. Then can be present like cerebrovascular accident or CNS vasculitis, tumors, primary CNS lymphoma, infections like HIV, HSV6, acute disseminated encephalomyelitis, NMOSD, and neuropsychiatric lupus are the other differentials. Thank you.